Ma'am, you are muted.
Ma'am, we are not audible. And we are still not audible.
Maybe you should check your device if you are using any headset. Maybe you can just change that. And Sangeet, can we just pause the recording till Dr. Vineeṭha is sorted? Ma'am, again you're muted. Sorry. Ma'am, you're muted.
Ma'am, you're muted. Okay. Sangeet, can you send a message by chat?
Ma'am, we can't hear you. You're muted.
No, ma'am, we can't hear anything. I think when you log in through your phone, we can all hear your sound, but when you try to log in from your device, it's not possible.
So, yeah, we get a response here from Sheila saying, yes, thank you. We get a lot of responses here saying Onden, Peridom, and yes, more. Yes, again, metoclopramide. Thank you so much. Yes, there's a lot of you saying, we've got about 20 odd responses here saying ondansetron, metoclopramide, domperidone, yeah, haloperidol. Thank you. So, and when is it that we actually make the call? Okay, thank you. There is something like Dexona also that has come up here in the chat. Promethazine. Wow, the list is just getting bigger. That's lovely. So the thing is that we know so many antiemetics, isn't it? And why exactly are we trying to actually work on how to choose which antiemetic in which situation, right? There are certain guidelines and there are ways in which we can bring about maximum outcome for the patient by choosing the right antiemetics. And that exactly is why we are going to have this class over here. Yes, we also have responses saying Pantop D. We combine sometimes antiemetics along with prokinetics and give combination therapies for patient. So moving on, can I have the next slide? Yeah, moving on, we will be dealing in today's class with by identifying the common GI problems in palliative care and also by the management of nausea and vomiting. How do we manage such patients and what is the pharmacological management, non-pharmacological management and things like that. Okay, next slide, please. So let's start off with this case history. Okay. So as you go through this case history, I want you to think in your mind, mentally, take a moment and see if how you would manage this case. Say, suppose you have this frail elderly lady walking into your OPD. Okay, she may not be that elderly. She's 54, but she definitely looks more than that age. She is having CA stomach and is on chemotherapy and was admitted in the general ward for treatment of UTI. She was admitted with vomiting, abdominal colic, and fever. And now she is tired and has been admitted for the completion of her IV antibiotic. So you have somebody with CA stomach who is already on chemo and now has UTI and is now admitted with symptoms of vomiting, abdominal colic, fever, and is there now for antibiotic therapy. She also complains of small, frequent, incomplete bowel movements for 4 days and is started today on laxatives. And she's accompanied by her younger daughter. And the question is, what are the issues here? And these are things that you will have to think of. And before we come to the answers, we are going to come back to this case scenario after a couple of slides, because I want you to think about how you will be addressing these issues as how you would. Like, what are the issues that you are seeing here? How would you like to investigate this lady over here? And how would you manage her? What we are going to do is we are going to have a picture of how we would manage this patient and come back after the class and see whether there is any difference in how we are going to think here on. Okay, next slide, please. Yeah. So coming to emesis, well, as much as, it is as distressing as the patient says it is to him, it is a defense mechanism of the body to remove all the toxic and harmful substances from the body after ingestion. And it is basically of 3 types: nausea, retching, and vomiting. And sometimes it is so much more distressing for the patient when he says he's very nauseous. They say that, no, doctor, just vomiting out makes me feel so much better. The feel of nausea itself is so much more distressing. So again, you have retching. So what are the differences between the 3? What are the differences between nausea, retching, and vomiting? Yes? Would you like to use the chat box? Nausea would be something. It's more of a... It's more of a feeling, exactly, like Dr. Deepak, Maria, Dr. Divya, Samiksha, all of you say it's more of a sensation to vomit. Yes, we have a lot more of you adding in. And then what about retching? When it comes to retching is more of a dry vomit. And says, then you have Kujit, who says it's more of the effort. It's more of the effort, the contraction of the muscles, right? Is trying to vomit out, but actually the vomit doesn't go out. It's more of an attempt, like what Dr. Ruhi is saying. Yeah, so exactly. And vomiting is actually when the contents are being thrown out, isn't it? Yes, so yes, it is about bringing out the contents. Nausea is a sensation. And Dishant says it's an act, retching is an active progress with no vomitus. Absolutely, absolutely. Next slide, please. Yeah. So nausea, like we all said, is an unpleasant sensation where vomiting is a forceful expulsion of the gastric contents along with the contraction of the abdominal and the chest wall muscles. And retching is a spasmodic respiratory movement against a closed glottis with the contraction of the abdominal muscles without the expulsion of gastric contents. Now, regurgitation is something else where the act by which the food is brought back into the mouth without the abdominal and the diaphragmatic muscular activity that characterizes vomiting. Next slide, please. So what are the different types of vomiting? Would you like to add on that? What are the different types of vomiting? We see a lot of vomiting, isn't it? For example, okay, I work in an oncology department, so I'm going to see a lot of different types of vomiting. Okay, I have answers over here saying drug-induced, projectile. Okay, that's a character of the vomiting, isn't it? It's projectile. Or maybe the characteristic, like it's intractable. Now, I'm talking about the types in terms of time, breakthrough vomiting, postprandial vomiting, bilious vomiting. Thank you for all those answers. Thank you so much. But I was wanting to come into absolutely, Dr. Pooja here says acute, chronic. So I'm talking about acute vomiting and delayed vomiting and anticipatory vomiting. Okay, breakthrough vomiting, refractory vomiting. These are all the different types that we are going to be looking at, because that's what our patients are going to be coming to us with. All right. So acute vomiting is that vomiting. Say a patient is being given chemotherapy, and within the 24 hours of chemotherapy, they start vomiting. And something which is occurring within few minutes to hours, and it resolves in 24 hours. So acute vomiting is that which is being prevented by giving prophylaxis. That is, we give pre-medication for chemotherapy with antiemetics. And this is basically to address the acute vomiting. Okay, so there is also another entity which is delayed vomiting. This usually occurs after 24 hours of chemo. There are chemotherapies like cisplatin, where, you know, after taking the medicine, say after the first day, the patient starts getting very nauseous and develops vomiting for, which may probably last for maybe a week or so. Now, there is something which is called as breakthrough vomiting. Now, breakthrough vomiting is something when you have given your patient ondansetron, and your patient is having vomiting before the next dose of ondansetron. So you are giving your patient ondansetron 3 times a day, and your patient has already developed vomiting by about 12 o'clock, when he's actually supposed to take his scheduled medicine at 1 o'clock. So that is what we call as breakthrough vomiting. And then you have refractory vomiting. Refractory vomiting is that which is called when vomiting is not controlled, when a prescribed frequency of drug is being given and you are not able to control it with your current antiemetic regime. Okay, and anticipatory vomiting is more of a conditioned response, where it may have been that the patient has come for chemotherapy the day, you know, the previous 3 weeks back, and has had a terrible experience. He has seen how distressful he was feeling. He has seen someone else vomit as well. And altogether, it was such a traumatic experience that the second time he's going to come for the chemotherapy, he enters the ward and he starts feeling nauseous. So this is called as anticipatory vomiting. Okay, even before the drug has been administered. So there may be exposure to various stimuli, which is reminding him of the prior exposure. It may be the smell of the hand rub. It may be the visual trigger of the, you know, the ward or the curtains or anything, which is triggering the anticipatory vomiting. So these are the different types. And can we go to the next slide? So why is it so important that we control vomiting? It has so happened that, you know, there has been studies and it has showed that more than 50% of people they have feared about this vomiting aspect that they have heard from many people even before the treatment has started. And when you counsel to them about how they have to start chemotherapy, they talk about, oh my God, is it chemo? I mean, I don't know how I'm going to take it. I don't think I will be able to take it. And when you explore more, they talk about how distressing it would be if they have to go through chemo because of the vomiting that they've heard of from many people. And even those who have taken vomiting, close to 50%, apparently about 45% of those people found that the chemo-induced nausea and vomiting, we call it a term, CINV, chemotherapy-induced nausea and vomiting. They said that that was the most intolerable symptom that they had. And why? So why are we actually trying to control vomiting? Would you like to add in? Why are we trying? Yes, Manisha says it's very distressing. Yeah, it is distressing for the patient. Dr. Pooja says it could make the patient dehydrated. Yeah. Why else do we have to control vomiting? Sheila says that could make the patient tired. Yeah. Dr. Divya says they have to complete their treatment. It's going to affect the compliance and it can be very stressful. Yes, Suhaila says about electrolyte imbalance. Preeti also agrees to it and talks about drug absorption. Noble talks about impaired nutrition to the patient. And Jyoti says something very important here. It may be a reason for them to even stop the treatment per se. Absolutely. And yes, Sangeeta also agrees with it for better compliance of pain medications and other medications. Yes, it is drastically going to affect the patient's nutrition, compliance, quality of life. Absolutely. Next slide, please. So it is going to affect the patient's daily functioning, the quality of life across all dimensions, physical, psychological, social, functional, spiritual, all dimensions, all right? And non-compliance to cancer treatment, refusal of effective pain medications. Now, this is going to be a vicious cycle. Patient is going to be in so much of pain because of his disease, and he is given pain medications. He is kind of okay. And that is when the chemotherapy is being started and the patient develops vomiting. The nausea and the vomiting is going to bring down his compliance and he refuses all medications. He even refuses pain medications. Patient is, as it is distressed because of the nausea and vomiting, and now all the more distress because he is in immense amount of pain. Quality of the life of the patient is absolutely downhill. When the patient is distressed, family is also distressed. Next slide, please. So now we get to explore what are the different causes for nausea and vomiting. So there are lots over here. I was supposed to keep it closed and ask you all.
So sorry, man.
That's all right. That's all right. Yeah. So we have different types of, we have different causes for nausea and vomiting. We have chemically induced nausea, we have gastric stasis, or it could be because of the distortion of the GI tract, it could be because of the serosal irritation, or it can be because of the raised intracranial pressure. It can be because of the movement-associated nausea and vomiting, or anxiety-induced environment. So chemically induced nausea and vomiting, what could it be? Chemically induced. Chemically induced? Yes, it could be any drug, right? Example, it could be chemotherapy drugs, yes. What are the drugs? Drugs like opioids, yes. We, on the palliative side, most of our patients, 80% of those patients who come with cancer, who have cancer, experience pain. So we do have a large amount of patients who we have to treat for their pain symptoms. So definitely opioids do induce nausea, and we have a lot of responses here saying chemotherapy induced nausea, vomiting. And then again, we have responses here like antibiotics, steroids, NSAIDs. Yes. So all these can cause nausea, vomiting. Then gastric stasis. Gastric stasis, it can be because of various reasons. It can be because of even opioids. Opioids causing constipation, constipation causing stasis, stasis causing nausea and vomiting. It's all a vicious cycle, right? And even electrolyte imbalances. Electrolyte imbalances can cause vomiting. There is probably a hypokalemia and things like that, and then there is a constipation, all that can also lead to vomiting. Stretch receptors, serocell irritation, again, the NSAIDs that you were all talking about, it can also cause. And serocell irritation, it can be even the ureteric colic, like someone is having a kidney stone and severe pain. Pain itself can cause nausea. And raised intracranial pressure. Raised intracranial pressure is mostly seen is projectile vomiting, like how earlier you were talking about the different types of vomiting. Yeah, so raised intracranial pressure is again one of the causes, right? Yeah. Can you just keep it open for the causes? The right-hand side? Yeah, thank you. So, coming from the beginning, yeah, chemically induced nausea, we like you all had rightly mentioned. Yeah, we have an interesting answer here. Roja says that vomiting also relieves headache. Yeah, in case of migraine, right? Most of the time during migraine, patients say that they feel so much more better once they vomit. Yeah. So coming to chemically induced nausea and vomiting. Yeah, she was also talking about raised ICT cases. Yeah, so chemically induced nausea and vomiting. We, like you all rightly said, opioids, antibiotics, cytotoxics, that is chemotherapy drugs. Now, again, also some gastrointestinal infections like toxins that are seen, or ischemic bowel that presents like melena and vomiting, and also gut obstructions. All right, and metabolic organic failures like uremia. All these can also present as chemically induced nausea. Now, gastric stasis. Yeah, we did talk about some drugs which could cause stasis. Now also anticholinergic drugs. Okay, so anticholinergic drugs, you know that some of them, they are antispasmodics also, and some of them like say hyoscine butyl bromide, they are also anti-secretory agents, right? So anticholinergic drugs can also induce nausea and vomiting. Opioids, ascites when the abdominal pressure increases, gastritis, all these can, yes, GU, gastric outlet obstruction, all these can also lead to, okay, and radiation. Okay, like earlier I was talking to you about chemotherapy-induced nausea, vomiting. Radiation-induced is RINV, radiation-induced nausea and vomiting. Okay. So the only difference is that in chemotherapy-induced nausea and vomiting, it's basically three distinct syndromes that we talk about. It's acute, delayed, and anticipatory. Whereas in radiotherapy-induced nausea and vomiting, it's just one clinical entity. Okay. So now coming on to stretch of the GI. So there you have the intestinal obstruction, constipation, when there's something like a stretch, like a megacolon, when there is really dilated bowels that is seen. Serocell irritation, like how we were talking about the liver metastasis or the ureteric obstruction. And again, NSAIDs or any infections of the GI tract can also induce. Cerebral edema, IC bleeds, infections, all that can also cause raised ICT, which will in turn cause vomiting. Now, even if you are planning to go on a nice holiday to a hill station, and as you go up, you may sometimes feel nauseous and start vomiting. So vestibular issues can also be one of the causes for nausea and vomiting. Anxiety, we were talking about anticipatory vomiting, isn't it? So anxiety is also another reason. Environment. Now, environment is one which most of us don't give much of importance to. Okay, the patient is in the ward and is probably having a room right next to the washroom, and there is some stale food also that is kept beside him. And all this together can be all multiple triggers for the patient, which is definitely making him nauseous and vomiting. Or sometimes it is, how relatives, they try to make a lot of nutritious food for the patient, which may not actually be palatable for the patient. And maybe it doesn't smell right for the patient. And all this can just be other reasons for a distaste or, a trigger for nausea and vomiting. Now, we have seen a couple of reasons over here for nausea and vomiting. But do you think there are still some other reasons which can cause nausea and vomiting for patients that you see in your daily practice? Do you think there are still other reasons? Oral thrush, absolutely. Sangeeta says oral thrush, such an important and very common reason for nausea and vomiting. Yes, migraine, total pain. Kunji, Dr. Divya, all pitch in with your answers here. It's all other reasons. And acute pharyngitis, dysphagia, or painful swallowing, tonsillitis, as Jyoti says. This is also other reasons. So this list of causes is not complete. Can I have the next slide, please? Yeah. So like the list goes on, there is also other very important other GI causes, upper GI causes in palliative care that very commonly we encounter. It is oral thrush. I so happened to meet this patient the other day. The patient who was suffering from carcinoma pancreas advanced stage. And this patient was having severe nausea and vomiting and on multiple antiemetics, yet not controlled completely. And I happened to see him. And that was my first consultation with him. And then I was examining him. And I was like, yeah, he's on multiple antiemetics, and rest, lower GI all looks fine. He's opening his bowels. And on examination, I see that he has a lot of oral candidiasis. And he was started on antifungus. And in a day or two, he was much, much better. So that is definitely one of the very common cause that we bump into in our patients. Halitosis, when oral care is not proper for our patients, most of them who are bedridden, and they are not able to take care of themselves, this happens. So halitosis is also one of the common causes which you have to rule out in your patients. Dysphagia, dyspepsia, hiccups, and mucositis. And this story that I was telling you about, this patient, he also had hiccups. And that's one of the other reasons which made me think, is he actually having esophageal candidiasis? So anyway, that worked well for him, thankfully. And again, mucositis. Mucositis is also another reason why a patient may present to you with nausea and vomiting. So when you go see a patient with nausea and vomiting, it's a checklist that you need to have in your mind. Sometimes it's one of these, sometimes it's many of these. So correcting the correctable causes is one of the first and foremost thing that we do in palliative care to address a symptom and to manage a symptom. Next slide, please. Yes. So now that we have found out this is the cause for why Mr. X is having severe nausea and vomiting, now we need to choose the antiemetic. Okay. How do we choose it? Which is the right emetic for him? So once you know what the cause is, you need to know which is the pathway which is affected, which is triggering the reflex, the vomiting reflex. And once you know the pathway, you identify which is the neurotransmitter receptor that is involved. And once you know the neurotransmitter receptor, which is mainly involved here, it is very easy to just pick and choose which is the potent antagonist to that receptor. And that's it. That is the antiemetic of choice for your patient. And then is how to choose the route of administration. If your patient is tolerating oral feeds, if your patient is able to tolerate oral medications, oral route is the most preferred. But if your patient is not able to retain any of this, which he takes orally, definitely parenteral is your route of your desired route of or recommended route of administration for this patient. And again, titrating the dose of this patient, it doesn't mean that, you just write an antiemetic and you go. You have to monitor your patient. You have to check if the frequency has to be increased or whether this is the only antiemetic that is required. Most of the times, your patients might require combination antiemetics, more than one antiemetic. Because there are multiple neurotransmitters that is probably involved. Right? Next slide, please. Yeah. So here we have a picture here showing the different pathways involved in vomiting. So as you can see in the picture, you know the cause. Once you know the cause, it could be anxiety, it could be some chemically induced nausea and vomiting, or it could be motion sickness, or it could be raised intracranial pressure. You try to identify which pathway is involved. So is it the CTZ? Is it the vomiting center? So you need to know where exactly is the pathway and which, definitely the CTZ has to send the signals to the vomiting center for the whole process. So we need to identify which receptor is involved. So here you can see a little color tabs given in the bottom showing you which receptor is indicative of the colors that are given here. So on the top, you can see, for example, if the patient you are looking at is probably having anticipatory nausea and vomiting, anxiety is the cause. So which part is involved? It is a brain, is a cerebral cortex. Okay, so that is a pathway which is involved. And you have to think of a drug which will act at that level, which will antagonize the receptor at that level. Whereas if it is a patient that you're looking at who has chemotherapy-induced nausea and vomiting, then you look at which are the receptor involved here. So you can see there are two colors here. You see the yellow color and the brown color, which represents the serotonin receptors and the dopamine receptors. So you may need combination antiemetics over here. You may need an antiemetic which antagonizes the serotonin receptors, and you may need an antiemetic which antagonizes the dopamine receptors, right? Although predominantly it is the serotonin receptors that is most affected in chemically induced nausea vomiting. All right. So this is how basically this chart works and is going to help you decide on which receptor, which pathway, which neurotransmitter receptor is involved, and thus choosing your drug is going to be given in the next chart. So next slide, please. Yes. So this is a very useful chart. It's got all the different antagonists given on the top. I mean, the receptors given on the top, and it's got all the different drugs that is given on the left-hand side. And each of this drug tells you which all receptors it acts. So, like in the first case that I was telling you, a patient who comes to you with chemotherapy-induced nausea and vomiting. So you did see that patient had involvement, I mean, the pathway that was involving the CTZ, right? The CTZ, mainly, you did see that there were two receptors that was involved there. That was the serotonin receptors and the dopamine receptors. So you look on this chart, which is the drug which would represent both. So as you know, that ondansetron is one of the choice of drugs for CINV and RINV. You can see in the chart that it most represents to antagonize the 5-HT3 receptors. And then what about those receptors? If your patient is still having nausea and vomiting, what do? You block the D2 receptors as well. So that is why you may need combination antiemetics for patients on chemotherapy. So go for, let us say, metoclopramide. So metoclopramide does have, as you can see here, some action on the serotonin receptors, as well as major antagonization of the dopamine receptors. Okay, so a combination of two would give you the best outcome for your patient. So you can take your time over this chart. The slides will be passed on to you. Can we go to the next slide? Yeah. So the route of antiemetic. Now, the next is choosing the route of antiemetic. This is definitely, like I said, according to the patient's condition and preference. Oral route is usually the best and the easiest. If vomiting is severe, you can try for IV route. You can even try subcutaneous routes. I don't know how many of you are familiar with using the subcutaneous route. It is not commonly practiced otherwise in institutions. In palliative care, we have found it most useful because many of our patients who are bedridden and they have difficult IV access and we have to give parenteral medications, subcutaneous route has been the most accessible, and sometimes even continuous subcutaneous infusions are given for patients who have refractory symptoms, right? So you can choose any of them. Suppositories, sometimes even rectal preparation of antiemetics are available in some institutions. Sublingual, I do try for children ondansetron sublingual patches, strips, I mean. So they work pretty well. They are fruit flavored and children like to have it. And sometimes even for some adults who say that, during this time of nausea and vomiting, I just can't even think of having another drug. And sometimes I tell them to have this strip, and that keeps them happy. Again, there are sometimes, yes, Roja was asking about what is CSCI. It is continuous subcutaneous infusion. It is given in syringe pumps. Okay. So transdermal patches are also available. Well, it is not available in my institution, so I have not used. I think there are transdermal patches for granisetron and things available in some places, right? So Next slide, please. Next slide. Yeah. So we were talking about pharmacological management, and always remember non-pharmacological management comes first and then comes pharmacological management at a home setting, especially when you go to a patient's home. It is so much more different from how you see a patient who comes to your clinic. You have to make sure there is a lot of fresh air that is coming into the patient's room. And if it is a vestibular trigger that has happened, make sure that the patient is having good bed rest to avoid vestibular stimulation, and also check for good oropharyngeal hygiene, and nursing the patient in the upright position to avoid regurgitation. And this goes the same for those patients who are also on Ryle's tube, because we do see patients who still have vomiting despite being on Ryle's tube, right? Sometimes it's increased speed, sometimes it's the position, right? Now, avoid situations which induce nausea and vomiting. Okay, it can be environmental, and suitable distractions. Now, when we are talking about suitable distractions, it can be anything like CBT, cognitive behavioral therapy. Now, that is experts that we need to come in and do that role, right? Next slide, please. Yeah. So distraction, as I was talking about, it can be anything. Like the other day, I had a patient who was coming in for chemotherapy. She's a dance teacher, and she has a great passion for dance. And she has severe vomiting. Okay, she has anticipatory vomiting. So I have put her on multiple antiemetics, and she tells me somehow, she's, even though she's not vomiting, she just feels kind of distressed when she sees the chemo ward. So I was telling her, why don't you try distraction? Put on your earphones and, just put some music, hear to some nice music with a lot of beats, and just keep choreographing a dance in your mind for that music. So something like that. I'm just giving you an example. So distraction, you can tell them about self-hypnosis or progressive muscle relaxation, biofeedback, systemic desensitization. Now, these are things probably a psychologist has to come into role. And this is most useful in anticipatory vomiting. And it can be used alone or along with antiemetic drugs, and it enhances the feeling of control and reduces the feeling of helplessness for the patient. Next slide, please. Yes. And what do you advise this patient to eat? This patient can hardly eat because he's very nauseous. And the nutrition also has to be maintained for such patients, isn't it? So you can advise them to have small meals. They may not be able to finish that, a plate of meal, but definitely ask them to break it down. Break it down into several portions and have small portions of meals which are spread with a gap of like an hour or so, or 2 hours or so. So try consuming most foods during the daytime, which is better tolerated than the nighttime. And it's probably because many people say that the breakfast went well for them, and then after that, it was just difficult. And advise them to have food which is usually easy on the stomach. Okay, maybe not very high fatty food and things like that. And never force feed such patients to eat. A common complaint which is told by many patients is that they are so severely nauseated and having vomiting, and the symptom is not controlled well, and the family, because the patient is not retaining any of the food, is somehow trying to stuff the patient again and again with something or the other, and which makes the patient more nauseous. This is such a common thing. I know many of you over there have also heard this. What about blended meal for the patient? Is Dr. HK, he was asking. Yes, definitely. That is also one thing that I do tell patients, because many of our patients who are taking chemotherapy, they develop severe mucositis, and they have a lot of painful swallowing and things like that. And even the slightest spice is not palatable for them. And what I advise is blended food, bland blended food for such patients. So that can be tried than solid chunks. Semi-solid foods or liquid food is also better tolerated. And sometimes if it is regurgitation or GERD, sometimes it works the other way around. It is when they take liquids and when they lie down, it's more of that which keeps regurgitating further. Okay. Now, cold food or at room temperature is better tolerated than hot food, like hot tea and things like that. Okay. So avoid fatty food or sweet food, extremely sweet food or spicy food. All this can trigger nausea and vomiting. Avoid fiber. And also carbonated drinks. Now, carbonated drinks, there are multiple opinions about it. Sometimes most people feel better when they take a soda. But say, suppose if it is sweetened soda, like a Coke or a Pepsi or something, you know, the sweet itself can trigger nausea and vomiting. Next slide, please. Barley can be an option, is what Dr. HK says. Thank you for that. And also what happens is sometimes, you know, it so happens that it is only this couple that is there at home and there is nobody else to help them. And if they have to eat, the patient herself has to go to the kitchen and cook the food. And also the patient is nauseated. So one advice that we can tell the patient, if they have to make food for themselves and they are nauseated, you can tell them to ask someone else to cook the food during the first few days that they're more nauseated. And again, if you have patients who are, you know, on strict diets like cardiac diet or diabetic diet, and they are severely nauseous, especially, you know, during advanced diseases and things like that, you can tell them to relax it a bit, because it is only a certain things that they can have during this period of time. So putting in a lot of restrictions can actually affect their nutrition. So you can actually ask them to relax the restrictions for some time. And definitely a dietitian can be consulted so that they can get the proportion of the carbohydrate and proteins and fat, everything on a paper, so that they are able to follow it and keep the nutrition going perfect. Yeah. So next slide, please. So what more can we do? Keep the mouth clean, do an oral care, wear loose fitting clothes. Again, important for patients with nausea and vomiting, tight clothes, no. Have fresh air or have a fan or an open window next to their bed. Limit high triggers like loud sounds, sights, or very pungent smells, which can cause nausea and vomiting. Okay, sometimes even floor cleaners. Okay, it can cause nausea and vomiting. And sometimes even mostly what many of the patients say, you know, the hand rub that we all use to keep everything very hygienic and clean and all that, that itself triggers nausea and vomiting. Okay, and always, be it any symptom, always give some contact information to the patient so that they can contact somebody who is on call to let them know if their symptom is not controlled. And so is it for nausea and vomiting. You prescribe the patient, someone who is really distressed with nausea and vomiting, and you're prescribing them some antiemetic. You always give them a contact information, probably of your OP number or the on-call person or MO who is there, and tell them to call back and let us know if you are not adequately relieved. Okay, because monitoring is very important. Role of ginger. Juhilat talks about role of ginger. Yes, it is seen to have some effect. Ginger has been studied in some settings, and it is seen to have good effect. So even advising your patient to take a cup of tea with ginger lime and a bit of honey is good. Yes, next slide, please. Nausea and vomiting management guidelines. So document which is the most likely cause. So you have to run that checklist in your mind. Like I said, it could be one cause, it can be two causes, or maybe more than three causes. Okay, you need to understand which causes are you dealing with and correct the correctable. What is reversible here? Treat the potentially reversible cause and the exacerbating factors there. It can be drugs, it can be constipation, it can be severe pain, it can be infection. Someone who's come with like a UTI, okay, urinary tract infection. Sometimes in elderly patients, I have seen, when I go for home cares, elderly patients, they are bedbound, and we are being called because the patient has severe vomiting. And when you go there and you examine the patient, you put your hand down and you start examining the abdomen, and there you go. When you palpate the abdomen, the patient has severe tenderness in the suprapubic area. And then when you start asking the patient, they tell you that, yeah, they have pain on micturition and things like that. So sometimes UTI also can present bizarrely, and vomiting can be maybe one of the only symptoms. So infection, cough, anything can be causes which are reversible. So you have to look into that. If you have to change your drugs, it was NSAIDs that was causing the nausea, vomiting, change it. If it is being constipation that is causing the nausea and vomiting because of increased abdominal pressure, open the bowels, give the patient enema. If it is severe pain that is causing the nausea and vomiting, hike up your analgesics. Find out what is the kind of pain that the patient is having. Is it nociceptive? Is it spasmodic pain? Is it neuropathic pain? Treat it. So all this has to be dealt with. The exacerbating factors has to be addressed, and you have to address the symptom of nausea and vomiting in a nutshell. Okay, review the dose after 24 hours, and if it persists after 48 hours, you have to review the cause. You are missing some cause over there. And remember, 1/3 of the patients will need more than one antiemetic. And if your patient is on IV antiemetics, and that has been going on well for 72 hours, and your patient is now good, try changing it to oral antiemetics. Okay. After a good 72 hours of no emesis, change it to oral antiemetic. Next slide, please. Yes. So pharmacological management, you have the different type of antiemetics here: anticholinergics, D2 blockers, prokinetics, NK1 receptor antagonists, antihistaminics, 5-HT3 antagonists, adjuvant antiemetics. So like I said before, there is someone who's come with a severe obstruction and having severe vomiting. Okay, you are giving antiemetics, it's not resolving. You try to bring down the secretions, anti-secretory effect also. You can give a hyoscine. Okay, someone who has severe vomiting, and then you understand, okay, let's try a D2 antagonist here. You can go for chlorpromazine. Okay, chlorpromazine is a large actin. Okay, and again, if the patient is having constipation and the patient is having severe nausea, vomiting, then you can go for a prokinetic drug. Okay, you are trying to bring down the nausea and vomiting, as well as you are giving a prokinetic drug so that it induces some amount of intestinal movement forward, and some prokinesis there will help to relieve the constipation as well. So metoclopramide, domperidone, or etopride, also now commonly used. So these are all different prokinetics which are also used. Now, NK1 receptor antagonists. These are antagonists which are used for anticipatory vomiting. Okay, aprepitant we use about on day 1 of chemotherapy, before the chemotherapy is given, that is prior to chemotherapy. Because this is for anticipatory vomiting, we give the first dose before the chemotherapy. 125 milligram of aprepitant tablet is given once a day before the chemotherapy is given. On the second day, 80 milligram is given. On the third day, 80 milligram is given once daily. Okay, so that is how aprepitant is given. But fosaprepitant is an IV preparation, which is given just as a single dose before the chemotherapy, but 150 milligram. Okay, then you have antihistaminics, like our Phenergan and things like that. And then you have the 5-HT3 antagonist. That is something which is most widely used right now. Ondansetron, Ganisetron, Palanositron. Okay, so ondansetron, granisetron and all are repeated often, whereas palanositron is not repeated as often as how ondansetron is. Palanositron, I have read some literature saying how it is preferably given at a gap of about 2 or 3 weeks, because it could, frequent doses could lead to cardiac toxicity. And again, we have adjuvant antiemetics. Okay, adjuvant antiemetics, there are agents we use like dexamethasone, benzodiazepines, things like that. Okay, so if your patient is having refractory vomiting, if your patient is having refractory nausea and vomiting, these are drugs that you can also try. Give your patient dexamethasone. Okay, I usually give 4 mg of dexamethasone, 1 in the morning, and give it for 3 days. Okay, and it actually helps to settle down. What actually happens is that, say in chemotherapy induced nausea and vomiting, there is also a lot of cell breakdown that is happening. Okay, because of the chemotherapy, there's a lot of cell breakdown and turnover that is happening, and this itself can release a lot of cytokines and inflammatory factors. So what dexamethasone helps to do is that it helps to bring down or decrease this. Okay. Now again, benzodiazepines, short-acting benzodiazepines are also preferred, like lorazepam. Okay, I usually give it HS for a few days. Okay, and I also give sometimes for some patients olanzapine. Okay, olanzapine is an antipsychotic. It also helps. Yes, Dr. HK asked, do we need to taper the dose of antiemetics that we use? It depends on the condition. Okay, say suppose we are dealing with chemotherapy-induced nausea and vomiting. We are expecting nausea and vomiting for a week, after which the whole nausea aspect fades off as it is. So there we have a chance to taper the antiemetic. Okay, now what we can do is that definitely changing from IV to oral, I have told you, wait for 72 hours, and then absolutely, like Dr. HK has just said, then we go for a PRN dose as and when required. Okay, but again, if the patient is requiring more than one PRN dose in a day, put the patient on a BD dose. Okay. Yes, and there was a request here on how aprepitant is given. Aprepitant is an oral tablet. It is usually given 2 hours at least before the chemotherapy. Okay, and it is given. I think the pack comes as 3 tablets. Okay, 1 tablet is of 125 milligram dose. The other 2 tablets are 80 milligram dose each. Okay, so the first tablet is given prior to the chemo on day 1. Then on day 2, when the patient goes home, he takes a 80 milligram tablet once a day. And then the third tablet is taken on day 3, okay, once daily, and that's it. It's just a 3 dose. Any role of lorazepam in anticipatory vomiting? Well, lorazepam has been tried. Lorazepam, olanzapine, all these things have been tried across anticipatory vomiting and refractory vomiting, and it has seen good results. So you can put the patient on lorazepam, yeah, even for anticipatory vomiting. Okay, and it is it's also seen that some studies have revealed that anticipatory vomiting is more seen in the female gender, in more younger patients, and those patients, women especially, those who have had hyperemesis during their pregnancy time, are also seen to have severe vomiting or anticipatory vomiting. Okay, and even those patients who have history of motion sickness, they also do give you history of severe, unsettled, uncontrolled nausea and vomiting. So these are some tips in the history you could ask, so that you can prepare your patients or give them some handy PRN drugs that will help them. Okay, next slide, please. Yeah, so we have couple of, this is the pharmacological management. So if you have chemically induced nausea and vomiting, you can give your patients drugs like haloperidol. Yes, haloperidol is antipsychotic, but is a very good antiemetic, right? And we necessarily need not have to start it at a high dose as 5 milligram that we usually do give for patients who present with delirium. For emesis, we can start even if it is oral preparation, we can start as low a dose as 0.75 milligram. Okay, I start at 0.75 milligram, and sometimes I have to go at 1.5 milligram 3 times a day. Okay, and metoclopramide, yes, again, we have a range of dose, 10 milligram to 30 milligram. You can give it 4th hourly. I usually give it 6th hourly or 4th hourly. Sometimes in terminal patients, we do give, much frequent. Domperidone, ondansetron, you are all familiar with, right? These are drugs that you're all familiar with. Flucloperazine, that is avastamidil, is also used, right? And so as you can see, now this is also what we were talking about, a scopolamine for the vestibular motion sickness. And then you have hyoscine butyl bromide, anticholinergic, octreotide. This is also an anti-secretory agent. All this helps to decrease the secretions, and thus helps to bring down the volume of the vomitings. Okay. And dexamethasone, well, I have written here 8th hourly, but necessarily does not have to be given 8th hourly. Once daily dosing of dexamethasone is more than enough for your patient. Okay, and I would just like to add one thing over here: metoclopramide. Metoclopramide, when you are giving parenteral for your patients, always keep a watch out for any extrapyramidal symptom. Okay, just keep a watch out for any extrapyramidal symptom in your patient. One thing. Second thing about metoclopramide, when you are giving metoclopramide, if your patient has come with severe abdominal pain because of some constipation or bowel obstruction, and that's the reason, you should not combine it with hyoscine butyl bromide. Okay, right. Next slide, please. Yeah, so now if you look at this, you will be able to have a better picture of what are the issues over here. You are having a urinary tract infection, and how would you investigate? You need to go through mentally all the causes of your causes for nausea and vomiting, and how will you manage it? I am not going into this right now because we are running short of time. We have to go to the case presentation for today. And next slide, please. This is Roy, who has a nasogastric tube. He has vomiting despite the nasogastric tube. The reasons: it could be a block, it could be a kink, or overfeeding. All right. That is also the different reasons for nausea vomiting. Next slide, please. Yes. So to summarize, when you have someone with nausea and vomiting, correct the correctable, non-pharmacological management, pharmacological management, and go for your intervention. Always monitor your patient and assure your patient after evaluating the patient, then manage the patient accordingly. And also in palliative care, it is not just about the symptom, it is about the individual as a whole. So it is covering all the dimensions of care. Okay. Yes. So next slide. Yes, that's my references. I have put a few case scenarios in the end. So that is just something that you can think about, just a little brainstorming you can do sometime later, whenever you get the time. And if you have any doubts regarding that, you can email me or WhatsApp me, and that's fine. Okay. Yeah. So thank you very much. I think we should move on to the presentation for today.
Thank you, ma'am. Thank you for the wonderful presentation.
Sankeet, okay, so we can start with the case presentation and we'll go to discussion after the session.
Okay, doctor.
Dr. Samiksha.
Yeah, good evening, everybody. Good evening. First of all, I would just like to say I'm Dr. Samiksha and we are having a chronic pain clinic. We are actually an anesthesia department and having a chronic pain clinic. So it's not many palliative patients that we've seen, and it's just a very recent thing that we've started doing. And this course is one of the first steps for the same. So this case is about a gentleman who's around 42 years, and he was diagnosed as a case of squamous cell carcinoma tongue, which was moderately differentiated. His presenting complaints were a lesion on the tongue bilaterally, which has gradually increased in size in left side very much more than the right side. This pain that he is having is very severe, NRS more than 8. It is so severe that he was unable to speak due to the pain, and most of the conversations were being done by his wife on his behalf. This patient was apparently all right around 4 months back when he started complaining of pain on the left side of the face. This was not very long, just 3-4 months back. Since 2 months, he's also having difficulty swallowing. A month back, he underwent a biopsy for the lesion. And after the procedure, the pain has increased in intensity to an unbearable kind. He even says 10 on 10 sometimes. This pain that he's having is constant throughout the day. It's pinpricking in nature, it's pulsating, and whenever he tries to open the mouth, it is aggravated, and thus that is what is hampering him to speak. He says that when he takes an injection of diclofenac, it just comes down to maybe 6 or 7. So not much relief with diclofenac, which he's presently on. On examination, his mouth opening was adequate, though very painful. The lesion is there, which is on the left side, 5 by 3 centimeter, right side 2 centimeter. And there is an induration which is present over the dorsal surface and left border of the tongue. The induration is extending over the left face and to the left neck. This has appeared after the biopsy. He's got Ryle's tube. The neck has 3 by 3 centimeter firm level 2 lymph nodes and 2.5 by 2.5 level 2 lymph nodes on the left side as well. His IDL could not be done because the patient was not cooperative. Biopsy was done in the OR, which the report says is squamous cell carcinoma tongue moderately differentiated. His CBC, LFT, KFT, RBS are all within normal limits. ECG, chest X-ray, contrast, MRI of the oral cavity have all been done. So by the primary team, the ENT team, he's been put on Augmentin, tablet Ultraset. He's been advised beta-kind mouthwash and injection diclofenac he was receiving. Now, when he said that he has got no relief with this diclofenac, he was sent to our pain clinic for the pain relief. And because he said that his pain has aggravated after the biopsy, probably there is some inflammatory component. So we put him on tablet Compiflam twice a day. And because it was a neuropathic kind of a pain, we started him on Gabapen NT 110 at night. And we advised a buprenorphine patch 5 mg for 1 week. We called him for a review, and after 5 days, and when the patient came back, he reported zero pain relief. So that time we put the patient on tablet morphine IR 5 mg 4 times a day and 5 mg SOS in between. So, but in 3 days only, the patient presented back with a complaint of very severe constipation and severe nausea, vomiting. Now, this patient has an history of some allergy to perinom, as told by his wife. So we put him on ondansetron 4 mg BD. And because he was having severe constipation, we told him to take enema once in 2 days, and Dalcolex 2 tablets at night he was put on. Regarding his psychological aspects, this patient, he was smoking for recreational purposes, and now he's in a big regret and guilt. His look is of a very, very depressed man, and he's been blaming himself for whatever has happened to him. His wife is very supportive. He has got 2 young, vulnerable kids, and the patient is really worried about the family. He was the only earning member of the family, so his finances are soon going to exhaust. That is his main worries. Before, he was having a very good social life, but now, for the obvious reasons, it has been compromised. So as of now, he was put on morphine, gabapentin, nortriptyline, diclofenac, ondansetron, and Dalcolax. The main concern is his pain, which is resistant, and his associated severe constipation, though the dose of opioid is not too much, but he's been having constipation since before only. Nausea, vomiting, which got a little better with ondansetron twice a day. So this is a 42-year-old male who was diagnosed with a case of stage 4 carcinoma tongue, and he is soon to receive treatment in the form of chemo and radiotherapy because it is an inoperable case, and the gentleman presented to our pain clinic for pain management. While being on opioids for the same, the patient has now developed severe and difficult to manage constipation. So the discussion points would be the treatment of constipation, pharmacological, non-pharmacological, nausea, vomiting. What is the need for prophylaxis in such patients? And to taper off the opioids, the need for interventional nerve blocks, which we advised him to come for at the later date. Thank you.
Thank you. Yes, so we have a case here. Thank you so much for that wonderful presentation. And this patient here definitely is in immense amount of pain. His analgesics have somehow led on to constipation, and the constipation has further aggravated his nausea, vomiting, and things like that. So here, the discussion points that has been brought up is the mechanism of constipation with opioids. Yes, that's for all of us. Would you like to use the chat box, all of you? How would you manage?
I think the constipation would be covered in the next session. So
yeah, I think so.
Skip these first 2 questions and start with nausea and vomiting.
Yeah.
So I think it will be better after the session.
Right. Yeah. Yeah, so we are having another session on GI symptom management or constipation and bowel obstruction. So I think we can reserve those questions on regarding constipation for the next class. Now let's think of what we can do for his nausea and vomiting, right? So let's get to the chat box and see how we can relieve his nausea and vomiting. He's already on Ondem. What do we do first? He's already on Ondem and he's having still nausea and vomiting. Yes, relieve the constipation. Dr. Divya says relieve the constipation. Absolutely. Yes, Dr. HK says evaluate. There can be also other causes. Absolutely. We have a whole checklist there, isn't it? We need to find out what it is. And Dr. Pooja says cremafin, get him into other laxatives. Rule out esophageal candidiasis, oral thrush. Absolutely, Suhaila says. And Ondem further worsens the constipation, so switch. So Dr. Deepak says that, yes, we need to switch because Ondem itself worsens constipation. Now we'll have to think of other measures like, say, haloperidol, because we had the presenter telling us that the patient has some reaction to metoclopramide. Yes, Ganaton. Ganaton also has seen to increase the motility of the bowel. So you may add that as well. And Dr. Pooja also says to look for brain mets and also to address the non-pharmacological issues. Absolutely. We are all on the same page right now. Now, treatment, well, maybe it is dyspepsia since his oral intake is less due to pain. Yes, we have so many causes. Any medications for pain that could be causing the vomiting, like tramadol, well, the patient is already on morphine here. And like Dr. Supdeep was trying to say, that it could be an opioid-induced nausea vomiting. Generally, opioid-induced nausea vomiting is self-limiting. It is seen only for about 2 to 3 days, right? And further after that, most often, the patient need not be on antiemetics for the sake of opioids, right? And food as laxatives can also be used. Yes, so prophylaxis. What do we do for prophylaxis? Basically, control the constipation, prevent constipation, and also if there are any other reversible factors for being the cause for his nausea and vomiting, we try to substitute it. Okay, we try to substitute that drug or whatever that is triggering the constipation. Or if it is any electrolyte metabolic causes, we try to rectify that, right? Yes, we also have other responses coming here for relieving the constipation, like stool softeners and fiber diet, right? And what about interventional nerve block to taper the opioids? Now, interventional nerve block can definitely be given for patients who have refractory pain. And what we need to know is that, was that pain chart over there optimal for that patient? That patient was on 5 milligram of morphine tablet 4 times a day on gabapentin, Hs of 100/10. It was a combination of 100 milligram gabapentin at night with the combination of 10 milligram of nortriptyline, right? So again, is it optimal? We know that morphine has a duration of action only for 4 hours. So we are in for hiking up the frequency as well as the dose per se. And also the kind of presentation that the patient is giving, it seems more like a neuropathic pain. So we need to hike up addressing the neuropathic pain of the patient, hike up the medication, the analgesics for that, like the gabapentin, which is only given here as a HS dose. We probably have to go for gabapentin 100 milligram 3 times a day, okay, rather than going for a combination of nortriptyline, okay. And yes, if the patient is not getting enough control with that, we will have to think of other measures, okay. Optimizing the oral pain management. So we also have to see if he has other reasons for painful swallowing, like rightly told before, any oral thrush or candidiasis or things like that, okay. So that also has to be managed with antifungals and things like that, right? So anything more to add? We are open for discussion.
So about this patient only, ma'am,
Yeah.
when case I had sent, this was the patient who had come to us around 3 times, but lately we received the news that he was undergoing the radiotherapy and he had this lingual artery rupture, and he sadly passed away there. So we've lost this patient very recently.
Okay. Electrolyte monitor, avoid hypokalemia is another suggestion. Would anybody like to add anything more regarding the patient management? So radiotherapy-induced mucositis itself is a reason for painful swallowing also, right? If you think of it on a general basis. So I do also advise sucralfate and oxymetazoline combination for such patients as oral preparation. Ask them to hold it in their mouth for some time and then swallow it. So that also helps to control the pain and things like that, and healing of the mucosa. Yes. So yes, please.
Yes, ma'am, please.
Yeah, I just wanted to know
Somebody-
if there is, there is lingual artery rupture, she said, right?
Mhm.
So that means the diagnosis which you said, which was T2N1M0, I think. I think that is to be re-evaluated because the lingual artery rupture with the radiotherapy, unless and until there is deeply, you said there was hardening of the upper neck.
Hmm.
So I think there is some the diagnosis. I'm not convinced with that.
Maybe it was something like it was a clinical, was it a
Right?
clinical staging that was done and then later
Maybe,
on the
right.
patient? Yeah.
Yes, maybe.
Maybe it
Yeah,
was not a pathologic. Yeah.
yeah. Very true. Okay, sure. Thanks. Thank you.
There was another comment from Dr. Anaswaya, the concurrence of total pain like psychological and social issues.
Yes. Absolutely. He was having so many psychological symptoms. I have forgot to address that in the middle of this. Yes. So that definitely has to be looked into. There's a lot of guilt, which is actually making him feel more depressed. So that can also be a reason for why he's having unsettled pain. So definitely that has to be explored over here.
If there are no more points to be discussed, I hope we can end the session.
Okay, doctor. Thank you, Dr. Vineeṭha, for the
Ma'am?
wonderful session. Ma'am, is there anything to add?
No, nothing. I just wanted to tell once again to everybody that, when you are using hyoscine butyl bromide, please do not, that is buscopan, please do not combine it with the antiemetic metoclopramide because that is being seen in many places and it tends to cancel the action of each other. So that is just one more thing I wanted to highlight. And you all have been really, really great. All have been giving so much wonderful responses in the chat box. And I really didn't know the time fly. And that's how actually, I had to end the session only by 6:15. So look forward to actually interacting with you all again for the next session. Yeah.
Thank you, ma'am. Thank you very much.
Thank you, ma'am. Thank you, everyone. Thank you for the
Thank you.
wonderful session.
Thank you, ma'am. Thank you.
Yeah.
Thank you, Dr.
See you all
Ajay, for
again
Yes.
on the next
presentation.
session.
Yeah,
Sorry, Sangeet?
I was thanking
Yes.
you for the session.
Yeah, can I just clear this? Hiccups also management, same approach. There's a
Okay.
question here.
So,
Yes,
Yes, ma'am, yeah.
haloperidol. Yeah, we do use metoclopramide for hiccup management, and also we use haloperidol in palliative care for hiccups management. And again, after that, if it's still not settled, we go for baclofen and things like that. Yeah. Thank you.
thank you everyone for
Yeah.
joining
Yeah.
and making it a very wonderful session. Thank you.
Okay.
Thank
See you in
you.
the next
Thank
session.
you.
Bye.
Thank you.
Yeah. Bye.